Good afternoon. My name is Karen Sampson-Hoffman, and I'd like to welcome you to today's Ask the Expert webcast. Your active preschooler, could it be ADHD? Today we welcome Dr. George Depaul, a professor of school psychology in the Department of Education and Human Services at Lehigh University and a leading researcher in young childhood ADHD. The Ask the Expert webcast series is presented by the National Resource Center on ADHD, which gives the general public access to top clinicians, researchers, and other professionals. The National Resource Center is a partnership between CHADD and the Centers for Disease Control and Prevention and serves as the national clearinghouse for the latest evidence-based information on ADHD. A recording of today's broadcast will be available on the National Resource Center on ADHD's website, Help for ADHD, in about 2 days. To view the recording sooner, please follow the same link you used to join us today. The recording will be available about 30 minutes following our presentation by using that link. We may not be able to get to all of your questions today. If you would like to talk with a health information specialist for further information on today's topic, please contact us Monday through Friday from 1 to 5 p.m. at 1-800-233-4050 or online at www.helpforadhd.org. Finally, following today's webinar, a brief survey will appear on your screen. Please take a couple of minutes to let us know what you think and how we can better serve the ADHD community through the Ask the Expert webcast series. It is a privilege to introduce today's guest, George Depaul. Dr. Depaul has provided clinical services to children with ADHD and their families, as well as consulting with school districts regarding the management of students with ADHD. He is the author or co-author of more than 190 journal articles and book chapters related to ADHD and pediatric school psychology, and he has published 9 books and 2 videos related to the assessment and treatment of ADHD. Dr. Depaul is a former associate editor of the School Psychology Review. He was School Psychologist of the Year in Pennsylvania, the recipient of a Senior Scientist Award from the American Psychological Association, and was named to the CHADD Hall of Fame. For those of you who would like to ask Dr. Depaul a question following his presentation, written questions can be submitted in the questions box on your GoToWebcast toolbar, as indicated by the red arrow shown in this slide. All questions are moderated, and we will get to as many as possible during the question and answer portion of the webcast. Again, we are very pleased to welcome today's expert. Dr. Depaul, if you would like to begin, please.
Thank you, Karen. And good afternoon, everyone. I appreciate everyone's interest in this topic, and it's certainly a pleasure to be able to talk to you this afternoon about ADHD in preschoolers. So before we get to your questions about that topic, I wanted to give you some background information in terms of what ADHD looks like in young children, diagnosis and assessment procedures that may be helpful for identifying young kids with ADHD, as well as talking about some of the challenges of diagnosis in this age group, and then finally focusing on treatment strategies that have been studied for this population. So, as a reminder, I'm sure all of you are fully aware of the diagnostic criteria for ADHD. And those same criteria, of course, apply for young children. And so we're looking at young children who have significant problems with inattention and or hyperactivity, impulsivity. The interesting thing is that there have been a number of longitudinal studies that have been conducted over the past few decades that have followed young kids, 3 to 5-year-olds who have been identified with significant ADHD symptoms at that age, and then followed them longitudinally through elementary school, secondary school, and beyond. And it's pretty clear that the ADHD symptoms tend to be chronic for at least half of these young children, even going back to Susan Campbell's early work in the 1990s, and then more recently looking at some of the studies that John Levine and his colleagues have conducted, as well as Ben Leahy and his colleagues. And actually that number of 50% is quite a bit higher in more recent studies because those studies have really applied fairly stringent criteria in identifying young kids with ADHD, and it seems that if one does a thorough assessment and identifies ADHD in this age group, that chances are it's going to be chronic to some degree throughout the lifespan. So it's not something that they're going to outgrow for the most part. It is something that parents and teachers are going to have to support them with, over the long term. In terms of prevalence of ADHD in young kids, we don't have a lot of great data on that, but the data that are available would indicate that at least 2%, maybe upwards of 4% of 3- and 4-year-olds may be diagnosed with ADHD, and clearly there may be others in the community who are not being diagnosed at this point who do in fact have ADHD. So the prevalence figures are a little bit lower than the percentage that you see in elementary and secondary school, but not substantially lower. Again, it's roughly in that 2 to 5% range. The concerning point with regards to ADHD symptoms in young kids is that, similar to older children, these symptoms are associated with significant behavioral and academic impairment. The idea that ADHD symptoms in young kids may be benign or not all that debilitating has really not been borne out by empirical studies. In fact, it's the opposite. These are children who are, depending on the measure that you look at least 1 to maybe 2 standard deviations below their peers or behind their peers with regards to behavioral control as well as academic skills. And just to highlight 2 things here related to impairment. One is that some recent studies have shown that preschoolers and pre-kindergartners are at higher risk for being expelled from school settings than older kids. They don't have the same protections that elementary and secondary school students have with regards to expulsion, and as a result, the rates of expulsion are really sobering in the preschool population for kids with behavior difficulties, including ADHD. And I know in some of the research studies that we've conducted at Lehigh University, where I'm at, where we've recruited preschoolers into studies, I can't give you an exact percentage, but it's a much higher than percentage than you would be comfortable with of kids who have been expelled from more than one preschool. Even at age 4 and 5, they've been they're on to their 3rd or 4th preschool because of expulsions. So that's certainly an indicator of behavioral impairment. In terms of the academic domain, there's a number of studies that have shown that even upon kindergarten entry, young children with ADHD are already behind their peers with regards to both reading and math skills. If we go to the next slide. Thank you. For some reason, I'm not able to control the slide, so if you're able to do that for me, that would be great. In terms of diagnosis of ADHD in preschoolers, the diagnostic procedures are very similar to what is done for older children. And the primary methodologies include a diagnostic interview as well as rating scales that are completed by parents and teachers. And this is, very similar to what is done with older kids. In particular, with the diagnostic interview with parents, we're obviously focused on the DSM-5 criteria for ADHD, but also wanting to get information about possible comorbid disorders as well as disorders that could mimic ADHD. And in particular, 2 disorders that we pay a lot of attention to with this age group when we're interviewing parents is oppositional defiant disorder, or ODD, because there's a frequent overlap of ADHD and ODD in this age group in particular. In fact, we did a fairly large study of ADHD preschoolers a few years back, and we had 75% of our ADHD preschoolers also met criteria for ODD. So it's a frequent comorbid relationship there. The other disorder that we want to focus on with parents, given this age range, is autism spectrum disorders and developmental disorders, which could co-occur with ADHD, but also, more importantly, could mimic ADHD in terms of the concentration problems, impulsivity, and high activity level. So we want to make sure that we are, in fact, dealing with ADHD and not a developmental disorder or autism. Parent and teacher rating scales are a core component of the diagnostic workup, and we like to include both a broadband behavior measure like the BASC, the Behavior Assessment System for Children, and then more of a narrow band scale that focuses specifically on ADHD and externalizing disorders like the Conners. And similarly, that combination is useful for getting information from preschool teachers as well. And the nice thing about these particular measures is they have normative data for the preschool age group, which is critically important, as we'll talk about in a minute. If possible, we also try to get direct observations of child behavior, either in a clinic setting, under analog conditions, having them interact, for example, with their parents around both play tasks and, play activities and more structured activities or tasks, to look at the degree to which the child and parent get along with each other, but also the degree to which the child complies with parent requests and how the parent responds to child behavior in terms of positive reinforcement versus punishment. Also, direct observation of child behavior in preschool settings can be very informative in terms of some of those same issues, but also giving us kind of a local normative context for the child's behavior, where we can compare the child's attention activity level to their peers in the same preschool classroom to see the degree to which they stick out or are different from their peers. And this is particularly an issue where you might have a concern that the behavior difficulties are due to more of a chaotic preschool classroom environment where the teacher may not have full control of the classroom, or may have inconsistent management skills, and so you want to gauge the degree to which that may be playing a role in what might look like ADHD. And then finally, as I mentioned to you previously, we want to rule out developmental disorders, including autism, and that we would do through both the diagnostic interview with the parents as well as rating scales, relevant rating scales. So now, if we could go to the next slide, we can talk about the challenges that one might experience in terms of diagnosing this disorder in early childhood. And there are certainly a number of challenges here that need to be contended with. One fairly major one is that, as I'm sure you're all aware, the symptomatic behaviors that comprise ADHD, namely inattention, impulsivity, high activity level, pretty much describe every 3-year-old. If you just take it at face value, it's a description of childhood, early childhood, and so these are behaviors that are relatively common in home and preschool environments. So we need to make sure that we're accounting for that in the context of our diagnosis, as I'll talk about in a minute. The other thing that is challenging is the degree to which children's behavior at this age varies across time, across settings, across people who are taking care of them or working with them. There's just such high variability in their behavior that one needs to be careful that we're taking into account behavior over an extended period of time, and also looking at situational factors that might be accounting for the behavioral symptoms that don't necessarily represent ADHD, but may represent differences in management style or differences in the quality of the different environments. So those are two big challenges when we're looking at 3- and 4-year-olds in particular. So for that reason, it's really critical to establish several things. One is that we want to establish that the symptomatic behaviors of ADHD are happening at a really high frequency relative to age and gender norms. So this is where measures like the BASC or the Connors come into play, where one can look at scores on these measures relative to other 3-, 4-, and 5-year-old norms and identifying kids who are at the, beyond the 1.5 standard deviations or more above the mean in terms of these symptomatic behaviors. So that's key. And that gets at that issue of the symptomatic behaviors being relatively common. Secondly, we want to establish that the behavior is chronic. Now, the DSM-5 suggests 6 months. Well, it doesn't suggest 6 months. It requires 6 months. Others have suggested a longer period of time, particularly for preschoolers. So, for example, Russell Barkley and others have suggested that one needs to establish that the symptomatic behaviors are occurring for at least 1 year to really show that the behaviors are chronic and are happening, on a consistent basis over time. Thirdly, we need to establish that there's impairment, that it's not just the behaviors that are occurring, but also that there's some impact, particularly in terms of social or academic functioning. And so measures that tap into social skills and early reading and early math skills are going to be very important as part of the diagnostic workup in order to establish that there is impairment. And then finally, as I've mentioned several times, we need to rule out other hypotheses for the behavioral symptoms, in particular, rule out the role that autism or other developmental delays or disorders might play. So then if we go to the next slide, we can talk briefly about treatment of ADHD in young children. And again, similar to the diagnostic protocol, the treatment procedures relative to ADHD in young children are fairly similar to the treatment approaches for older children and even adolescents, with, in particular, the two most strongly empirically supported interventions for ADHD being behavioral interventions implemented at home or school, and then psychotropic medication, in particular central nervous system stimulants. So just to briefly talk about each of those, the behavioral intervention piece, most of the research here with young kids is focused on parent education, family education in the use of behavioral procedures at home. And there's been a number of empirical studies that have supported this approach. For example, Carolyn Webster Stratton's work with the Incredible Years series, and there are others as well, but Webster Stratton's work in particular is notable here. And clearly that is a primary treatment approach for ADHD in young kids, and in fact, arguably it is the first line of treatment for ADHD in young kids, even before medication. In addition to the behavioral interventions, it's really important to work with parents and preschool teachers to support the development of early reading and math skills beyond what would typically already be in place for a young child. As I mentioned to you previously, these are kids that are at risk for coming into school behind their peers in academics, and so it's really important that those skills be supported. So, for example, strategies such as dialogic reading or embedded math instruction, where you're exposing children to mathematics principles through everyday activities, is really important. I want to make sure that I contrast that with a notion of extended drill and practice and forcing kids to practice skills at a high rate in this age group is really not developmentally appropriate, and also can backfire in the sense that kids could get really turned off to academic activities by being forced to drill and practice. What I'm talking about are more everyday embedded activities that include reading to children on a frequent basis, and then discussing math in the context of just everyday activities. Thirdly, it's really important to focus on injury prevention and safety promotion. Young kids with ADHD are at much higher risk than their peers for accidental injuries due to their high level of impulsivity and activity, higher rate of emergency room visits, higher rate of broken limbs, accidental poisonings, things along those lines. So it's really important that families act proactively to prevent injuries, to prevent accidental poisonings, and so forth. And then finally, psychotropic medication certainly can play a role, particularly for those with really severe symptoms. And the most famous work that's been done on this that you may be familiar with is called the PATS study, P-A-T-S, which stands for Preschool ADHD Treatment Study. It was conducted about 10 years ago or so now, the largest medication trial with young kids with ADHD. And the good news found that stimulants, primarily methylphenidate, reduced symptoms of ADHD both at home and preschool to a significant degree. So that's the good news. The not-so-good news was that the side effect frequency in this age group is higher than for older kids, and in particular there are concerns about growth inhibition, and the PAT study did show some reductions in the velocity of weight gain and height gain that would have been predicted without medication. And as a result, some of the families of kids in the PAT study itself, where there were positive effects with stimulants, despite that, they chose not to continue with medication following the research because of the concerns about side effects. And it's also important to note the American Academy of Pediatrics issued treatment guidelines for ADHD a few years ago, and they strongly recommend behavioral interventions, as we were talking about earlier, that those should precede medication use in this age group. So anyway, hopefully that gave you a quick rundown of some major concepts with regards to what ADHD looks like in young children, how we might go about diagnosing it, some of the challenges associated with that diagnosis, and then a general discussion of treatment strategies for ADHD in young kids. So at this point, I'm open to any questions that you may have.
Well, thank you. And we do have questions. They have started coming in. And again, if you have questions that you would like to ask Dr. Depaul, you can submit them now in the question box to the left of your screen. And our first question is actually coming from several of our viewers today, and they are wondering how young is too young. You mentioned a moment ago the American Academy of Pediatrics has some guidelines. What age, when we're talking young child and diagnosis and assessment, how young is too young?
I don't know if there's a cut and dried age with too young. I certainly am very hesitant to diagnose ADHD certainly younger than age 2. In fact, I've never done that in my career. Between age 2 and age 3, it also is very challenging for some of the reasons I mentioned earlier in terms of the type of that these behaviors are basically descriptive of this age group, and so it's very difficult to identify somebody even between the ages of 2 and 3, although certainly I have run across a handful of kids in my career where it was fairly obvious that they were outside the range, well outside the range of expected behavior in that age group. When you start getting into age 3 and 4, we have the methodologies really to do that, I think, in a very reliable and valid fashion, provided that we, are taking into account some of the challenges that I mentioned to you earlier. So how young is too young? I would certainly say younger than 2 to me would be, I've just never done that. I'd be hugely uncomfortable to do that below the age of 2. And then between age 2 and 3, I'm still very uncomfortable, but under certain circumstances, with the right data, could make that diagnosis.
Okay, thank you. I think that's very helpful. One of our other participants, she has another question. Her son's pediatrician is suggested that her son, who is 3 years old, may have ADHD and is trying to have a diagnosis, do the evaluation. And she's saying that her son does not really have significant behavioral issues, and she's wondering what should she do? How should she respond to the doctor in this regard?
So I guess I want to make sure I understand the question. So the question is that the child's physician is suggesting the possibility of ADHD. However, the parent is not seeing those behaviors or not seeing those difficulties. Is that the nature of the question?
Yes, that does seem to be the nature of the question. The parent is saying that her son doesn't have significant behavioral issues, but the doctor is saying this looks like this may be an instance of ADHD.
Wow. Yeah, that's a pretty unusual circumstance because most cases, physicians are responding, particularly with this age group, physicians are responding to parent report of significant difficulties related to possible symptoms of ADHD. So I'd be curious in that instance of getting more information from the physician as to why he or she is questioning the presence of ADHD. Is it based on their observations of the child's behavior during physician visits? Are they getting information from another source, a preschool teacher or some other source that would indicate concerns? It just seems to be a fairly unusual circumstance. If the parent is not observing significant difficulties at home, it would be pretty unusual for a child to get the diagnosis of ADHD in this age group. I've certainly seen that happen, and I've been part of evaluations where we've done that for older kids, where the symptoms are quite alive in the school setting and muted at home. But when we're talking about 3- and 4-year-olds, 5-year-olds who aren't in elementary school yet, it would be really unusual to go forward with a diagnosis of ADHD without parents reporting significant symptoms. So I would really question the doctor more thoroughly in terms of on what basis is he or she reaching this conclusion, and perhaps providing even more stronger advocacy from the point of view of the parent that they're really not seeing difficulties at home.
Okay, thank you. I think that's a good way of addressing that issue, because it is a slightly unusual one. Usually it is the parent that brings the question to the doctor.
Yes.
Well, our next question now is coming from Sarah, and you mentioned earlier that the primary mode of intervention is to begin with behavior management, behavioral treatment. And Sarah was wondering if you had any suggestions for how parents could go about finding a behavioral interventionist or a behavioral therapist to work with a young child.
Right. So that's always a challenge, particularly in geographic regions that outside of large cities and so forth. Sometimes it's difficult to find a behavior interventionist or behavior therapist. A couple of things to think about. One certainly would be through the local, if there's a local CHAD support group. Very often the local CHAD support groups will keep a resource directory for parents of psychologists and other mental health professionals who work with families with ADHD in the area, and that could be very helpful in terms of identifying folks who might be able to provide behavioral support. The other organization to look at is there's an organization called the Association for Behavioral and Cognitive Therapies. It's ABCT, and they have a website, abct.org, where you can go to that website, and I believe they have a directory of behavioral therapists who, by region, by location, and that directory will indicate, the practitioners on that directory will indicate their relative areas of practice, and so one would search for behavior therapists who practice with ADHD, with the ADHD population. And that's definitely an organization where practitioners who belong to that, clinicians who belong to that, will typically be well-versed in behavioral strategies. So I think those are the two primary ways that I would try to go about it. The local CHAD support group that might have a resource directory, and then the ABCT organization. And the other thing that you could do also is ask your child's physician or pediatrician. Sometimes they are going to be aware of who in the community provides behavioral intervention support.
Well, thank you. And again, if you are interested in finding a CHAD chapter, you can find those on the CHAD website at www.chadd.org and look underneath the Resources tab. And we have our listing of chapters for each state, and we also have a listing of professionals who've made themselves known to us. So we have a professional directory that you can take a look through. Well, our next question comes from Alice, and she was wondering, when should a parent think about explaining to their child that they have ADHD, and again, in a way that is age appropriate for a young child?
That's a really good question. I certainly wouldn't suggest getting into ADHD per se with 3- and 4-year-olds or 5-year-olds. I think that the approach that I've typically taken with early elementary school kids has been to talk about strengths and weaknesses and discuss how every individual, whether they're a child or an adult, have particular strengths and specific weaknesses, and that in their case they have strengths in a number of areas, and you would go help them identify what they're good at and what strengths they have, and be encouraging to be to think broadly about those things, and then also help them to think about some of the areas that they might have more challenges or have some weaknesses, and talk about how the combined weaknesses of problems paying attention and focusing on things, and maybe sometimes acting quickly without thinking, that combination of weaknesses can lead them into having some difficulties at home or at school, and help them think about some of the instances where that happens. And that the good news is that, first of all, they're not alone. There are many kids and adults, really, that have that difficulty. And then secondly, that you as a parent and their teachers are going to work together to try to help the child to address those weaknesses, to work on them. And that it's going to be a long haul, but we're all in it together, and that we have some good ideas on how to help them. To be honest with you, I haven't really done that too much with young kids, with 3- and 4-year-olds. We've really focused on more very specific situational factors to identify, rather than a broad-based discussion of certainly of ADHD or the behaviors that comprise it. But with early elementary kids, first and second graders, I've found that discussion of strengths and weaknesses to be very successful in helping them to understand this, and really don't get into a discussion of ADHD as a disorder until the kids are older, later elementary school and beyond, so that they're equipped to really understand it.
Well, thank you. And I think that's a good approach. It is a question that we do get frequently here at the National Resource Center on ADHD. Well, our next question now comes from Lori, and she has a 4-year-old son who has been diagnosed with ADHD. But her son is also very difficult. He can be destructive and aggressive, and he has some sensory issues also going on. And she was wondering, after behavior therapy and behavioral intervention, are there any medications that have been studied in young children who have anxiety or aggression that have been effective? So we're talking, along with ADHD, co-occurring anxiety and aggressive tendencies.
Yeah. Well, first of all, that's not all that unusual for a young child with ADHD to also be aggressive. That's so certainly practitioners in the community are going to be familiar with that combination. the challenge is that we don't have substantial research on that combination in terms of medication therapy in young children. With older children, you sometimes see the combination of stimulants with medications such as clonidine, which is marketed as Catapress, or 10X, where that combination of a stimulant with clonidine or 10X can reduce aggression in older kids. I don't believe there are any specific studies of that combination of drug in young children. Doesn't mean you couldn't approach that or potentially engage in that, but we don't really know what that combination of medications does in that age group, and we're not also, because there's no research on that combination, we're not sure what the side effect profile would be either. So it would have to be done with caution. So unfortunately, we don't have a lot of research base to work with there. I'm assuming that in this case they haven't tried stimulant medication. If that hasn't been tried yet, that certainly would be a first approach beyond the behavioral procedures to introduce a stimulant to the mix, because it could be that the combination of a stimulant with a behavioral intervention could not only help with the ADHD but also reduce the aggression. But short of that, unfortunately, we don't have a substantial research base to really guide our choice of medications with this age group.
Okay, thank you. And it is a very important question, and as you said, going slowly and steadily in finding the answer and working closely with the doctor. Well, our next question now is coming from Justin, and he has another medication question for us. He was wondering how long do you go working on the behavioral management before saying this is not working, we should do a medication trial, or should you try a new doctor, new practitioner first before moving to that medication trial?
Another good question, and there's no real cut or dried answer to that. It really does depend on the circumstances. Certainly, in the case of kind of typical behavioral intervention, parent education, and follow through on behavioral interventions, those treatment approaches typically are implemented for at least several months before one would decide whether they've been significantly helpful or not, because it does take some time to build up the skills in implementing them, and also take some time for it to have an impact on the child's behavior. But beyond that, I guess some other questions that might come to mind is if the procedures are not feasible that are being suggested, they're not feasible for use in the home, maybe trying to work with the behavior therapist to identify things that may be feasible. Because sometimes what I've seen is that behavioral interventions don't work because the parents or teachers are not able to implement them consistently. And so therefore it's not a failure of the strategies themselves, it's the fact that there's some roadblocks for the parent or teacher to implementation. And a lot of times that may be just because of time or resource issues, that there's not enough resources to implement the strategies. And I think it's important to work with the therapist to identify, what are the barriers to the treatment implementation if that's an issue. If it's a case where, the strategies have been tried and they've been tried, faithfully for a couple of months or beyond, then I think the question about medication becomes more pertinent, more relevant. And I think that is helpful to talk to a physician then at that point to say, here's what we've tried. It's helped in some ways, it hasn't helped in others. and we're interested in talking with you about the possibility of medication. So again, it really depends on the circumstances, and I think before jumping to that point, one would want to at least give it a few months, and then one would also want to make sure that the strategies are being implemented pretty faithfully, pretty consistently before giving up on them.
Well, thank you. Now we've got a question from Susan, and pardon me, our next question will be from Susan, but this one is from Judy. And she was wondering if you could give some specific examples of behavior interventions. You've mentioned this, your previous answer, you were talking about these interventions. What would those be? What would they look like? What could a parent do?
Sure. So the way we kind of organize our the behavior management strategies that we work with parents on is in several different categories. So one of the things that we think about is what can we be doing proactively before a challenging behavior occurs to reduce the probability that the challenging behavior will actually occur. So, for example, if we know that when we go to the grocery store with the child, that the child will, when we get in the grocery store, they run around, they don't stay by our side, they touch objects on the shelves and sometimes knock stuff over, or they bump into people in the aisles, or maybe they beg for candy or beg for other items that for the parent to buy them, whatever. So we know in advance that when we go into the grocery store, challenging behaviors are going to probably occur. So what we do is we work with the parents to think about, all right, what can we do before we get to the grocery store to reduce that probability? So one of the things we'll do is talk to them about when you get to the store, you review, prior to entering the store, we review the rules. Stay close, don't touch, don't beg. So it's like 3 or 4 very simple rules, and then identify for the child if you're able to follow those rules. Mommy will be really happy, Daddy will be really happy, and we'll get to do some nice thing together, or we'll get you a treat or something along those lines. So there's a positive reinforcer that's associated with it as well. And then once you get into the store, you're laying on the praise, almost immediately, that they're following the rules, that they're staying close, they're not begging, they're not touching, and do that frequently throughout the grocery store trip. So the idea here is kind of a combination of thinking ahead as one category of behavioral strategy, thinking ahead and planning ahead, and then the other category being making sure that we are taking a positive approach and praising and reinforcing the following of rules or the following of instruction. The other type of strategy that we take, particularly with this age group, is to focus on communication and instruction in communicating one's needs. There are certainly many instances where kids engage in challenging behaviors to communicate a need. So, they want a toy that somebody else is playing with, so they just grab it out of the child's hand. Or they don't want to sit down at dinner, they prefer to keep playing, and so they keep playing, they ignore the parent asking them to come to the dinner table. So what we try to focus on is helping parents to help their children to verbalize their needs rather than engage in challenging behaviors. So in the instance of wanting a toy, to be able to say, please, could I borrow the toy for a few minutes, and so using verbal behavior rather than grabbing it out of a child's hands. And then as children exhibit these verbal communication skills, to reinforce those. So when they use their words to ask for something, it doesn't mean that you automatically comply with every verbal request the child makes, but you try to positively reinforce those as frequently as you can, so that they learn the distinction that the way to get your needs met is to verbalize your needs, and that they won't necessarily get met every time you verbalize, but very frequently they will. Versus if you act out or you behave in a way that's inappropriate, you're not going to, as a way to communicate your needs, that's not going to get reinforced. The other thing, of course, is a focus on reinforcement just as a general principle, and we will work on trying to change the dynamic. A lot of times the dynamic in the family is negative, where the child's behavior is being punished frequently in terms of child's being yelled at or reprimanded or punished in other ways on a frequent basis. And that's easy for parents to fall into that trap because their kids are difficult to manage. It doesn't mean that they have poor parenting skills. It means that they're in a situation that's very challenging, and typical parenting strategies aren't going to work. So in those situations, one has to really lay on the praise, lay on the positive reinforcement at a much higher level than in a typical family because of the challenging circumstances. But we're trying to change the dynamics from a punitive interaction between parents and kids to more reinforcing. So we're helping guide parents to use of specific praise. We're helping them to identify use of reinforcing activities following compliance. So in other words, when the child complies with a command or request, that there's some positive outcome for the child in addition to praise. Maybe they get access to something they enjoy for a short time. Maybe they're able to do something a little bit later in the evening that they enjoy. So it's tied to a reinforcer or reward. And it's kind of a combination of all these things where you're planning ahead, you're teaching communication skills, you're reinforcing positive behavior. It's that a more comprehensive protocol that we emphasize.
Oh, thank you. Well, our next question, as promised, comes from Susan. And she was wondering, how do you respond? What would you suggest a parent do when another parent says, oh, the child will just grow out of it, when it's another parent, another family member, oh, they'll just grow out of this behavior, and yet there is a diagnosis of ADHD or a likely diagnosis?
Another excellent question, and that's an opportunity, obviously, to educate a relative or a friend about ADHD. And I guess I would suggest to do that in a non-defensive way, to say, that's basically, that's what I would have thought before I learned more about ADHD. ADHD, and what I've learned about ADHD is that it does tend to be chronic. It does not tend to be outgrown by most kids, and it would be nice if that were to happen. But similar to, diabetes or, other quote-unquote physical illnesses or chronic physical illnesses, ADHD is a disorder of the brain that the child may have inherited or acquired in some way, and that it's not likely to go away. And for that reason, we as parents have to focus on trying to support our child over the long term. And I think if the individual, persists in saying, well, I read something on the internet that would suggest that this is all a myth and so on and so forth, I would suggest letting them know that there are reputable websites that they should check out, like the National Resource Center or CHAD or the National Institute of Mental Health or other organizations like that have very accurate information about ADHD that would suggest otherwise. And to remind individuals, if they're getting their information from the internet or other sources like that, that one cannot always trust what one reads on the internet, and I'm sure every individual could come up with other areas where they've come across stuff that is just baloney on the internet, and that's true for ADHD as well. So the general approach would be, in a non-defensive way to say, look, I understand where you're coming from. That's what I thought about ADHD before I had a child that was diagnosed with this condition. But I've done a lot of reading about this. I've had a lot of support from professionals that would suggest otherwise. And if you're interested in this, here are some websites to check out, and I'd be more than happy to talk to you further about it.
Well, thank you. Well, we've got a question now from Charity, and she has a child in daycare, and she was wondering how can she get her child's daycare providers and preschool on board with her child's behavioral needs. He has an ADHD diagnosis, so how do you get the daycare providers to be part of the solution and follow the behavioral management?
So it sounds like they have a diagnosis and maybe even a plan that they're implementing at home. Sounds like from the nature of the question that may be the case. I think I would approach it as in a very straightforward fashion of first of all requesting a meeting with the relevant teachers and maybe bringing some materials from whatever professionals this family's working with, as well as maybe from the web or any books or other resources they have, and coming to the meeting and saying, we want to really work with you to address my child's difficulties. I know that he or she's having some difficulties in the daycare setting, and we want to share with you some things that have been helpful at home in managing his behavior, and we think they could be helpful for you as well. And here's some of that information. How can we go about working together? And so just kind of communicating the desire to partner with them and to be very open about what has worked and what has not worked at home. And, also saying, we understand that the daycare setting is different than the home. And, it may not be exactly the same thing that's going to work here at daycare that works at home. But we want to give you some ideas that we've found helpful and then maybe talk to you about how could we implement some of these at daycare and how can we help support you as the daycare provider to do that. So, trying to build that relationship in a positive way. What you want to avoid is coming in like gangbusters with, we have the answers here. We know what we need to do for our child, and, you need to do this. That may very well be true, that you know what's best for your child and that you have the plan that will work. But if you come in that way, it's going to put the daycare folks on defensive, and they're going to be resistant, probably just very naturally to that. So you want to come in from a collaborative standpoint and, suggest that we can work together and that here are some ideas to share with you. What do you think might work? How can we help support you in implementing these things?
Well, thank you. Following up the preschool question, we have a question now from Zach, and he has a child who has ADHD, and he was wondering, is there a benefit to holding his son back in kindergarten, doing kindergarten 2 years in a row, to give his child more time to mature? We know that kids with ADHD tend to be a little more immature than their peers as part of the nature of the disorder. So is there a benefit to holding a child back in kindergarten, or is this something that could backfire on a parent?
Yeah, that's also a very excellent question. In general, retention is not a great idea. The literature on grade retention, whether it be kindergarten or later in school, would indicate that the only time that retention really is beneficial by itself anyway, the only time that it's beneficial is if the child has missed a lot of school due to illness or other reasons, that they've missed a substantial amount of instruction or school time. And that doesn't sound like that would be the case in this case. And if you're waiting for maturation to address the issue, that's really not going to make a big difference. And in fact, could backfire in the sense that the child may interpret the retention as failure and also may be hurt by the idea that his or her friends are moving on to first grade and beyond, and they're back in the same situation. And so socially, it certainly does not enhance, typically does not enhance the social status of these kids, and these kids are already at risk for rejection by their peers and struggling to make friends, and this does not set them up in any way. The key thing, I think, that I would suggest they would focus on is what can be done, assuming they get promoted to first grade, what kind of supports can be put in place in first grade to ensure that that the child has a better year. And I would wonder, has the child been considered for Section 504 accommodations as an individual with disabilities, because students with ADHD can qualify under that, or if they also are, in need of special education, one could request an evaluation related to that, where an IEP or individualized education plan is put in place. But even without those formal, accommodations or IEPs, one would want to work with the school in terms of touching base with the first grade teacher as early as possible, maybe even over the summer, to strategize on how the child's difficulties can be managed in the first grade classroom. Under those circumstances, now the child is still with their age mates, still with the friends they've made in kindergarten, does not see school as a place of failure, and is getting the proper support, hopefully, as they move on, to the next grade level.
Thank you. We've got several of our participants who are wondering if you could elaborate just a little bit more on some age-appropriate behavioral strategies, maybe a couple for home and a couple for school that parents can share with the preschool teachers. Behavioral strategies are very important and very much an interest for our participants today.
That's great. That's great to hear. Let's see. What for the preschool situation? It's kind of the same major framework that we try to work with teachers to think about what can be done proactively, what can be done to help children to communicate their needs in an age-appropriate way, in a more behaviorally appropriate way, and then thirdly, the category of reinforcement and consequences. And so what we will do is try to focus in, help teachers to think about, okay, what are the primary situations where the challenging behaviors are occurring, and to focus on those first. We're not going to try to address behavior through the whole school day. We're not going to try to address, for that matter, behavior at home across every situation. We're going to prioritize one or two situations first, and we're going to look at each category of intervention that I just described in each of those settings. So, for example, circle time can often be a challenging time for students with ADHD in a preschool setting, and that's where preschool teachers, like reading a book to a small group or engaging in a singing activity or a movement activity or a discussion with a small group of children. And kids with ADHD often have trouble, staying still, waiting their turn, and then following through on what they're supposed to do. So what we would do with the preschool teacher is to say, okay, let's identify, 2 or 3 things that we want the child to do during circle time, and right prior to circle time, take the child individually, remind them of those, maybe decide on some cues, some nonverbal cues, finger movements or head nods or an eye wink or something like that would signal to the child that they're starting to deviate from the rules, but also, more importantly, praising the child as they engage in the appropriate behavior. The other specific strategy we'll use in that situation is something called pivot praise, where the teacher will identify, let's say that the child with ADHD starts to get fidgety and is moving around a lot, maybe calling out without permission. What the teacher would do in that instance is praise the students that are following the rules very specifically. Johnny, I like the way you're sitting still and listening and waiting your turn, and then maybe going through a couple of other students' names and praising them specifically with the hopes that the child with ADHD will then comply, even if it's for a few seconds, where they stop what they're doing and pay attention. And then you pivot at that point. The teacher pivots to that student with ADHD and praises the fact that they are now sitting still and paying attention. We found that's really effective strategy in group situations, and particularly in preschool, that use of pivot praise. So again, basically, it comes down to the use of proactive strategies to help promote appropriate communication, and then the use of positive reinforcement and consequences relatively immediately following appropriate behaviors.
All right. Well, thank you. We have one last question, and this has come from a couple parents who are hearing something that research doesn't bear out, but they are wondering if there are any studies, if there's any information that says that too much screen time is a cause of ADHD. They're hearing from family, from friends, from others saying, oh, your child has ADHD or your child doesn't have ADHD. They just need to stop watching so much TV, stop being on the computer. What would you say? Is there anything that you can offer them to say to those who might be suggesting that ADHD is caused by excessive screen time?
Yeah, well, I mean, there are even researchers who believe that. Unfortunately, it's a fairly common idea that is out there in the community, and I don't know whether you're going to fully convince people. I've kind of given up on trying to convince the world of the truths behind ADHD, but to the extent that they're willing to listen, I think that one can talk about the fact that all of these studies that purportedly show that TV viewing or other viewing causes ADHD are not experimental studies. They're not true experiments. And without a true experiment where one would actually randomly assign kids to different levels of screen viewing and then monitor their ADHD symptoms over time, one cannot definitively prove one way or the other that screen time causes ADHD. All of the studies that have been conducted on this have been correlational, meaning that they've just looked at the association between the amount of screen viewing and the number of ADHD symptoms. And some of these studies have found a correlation between those two factors, but that could be for different reasons. It doesn't necessarily mean that the screen viewing causes ADHD. It could actually be the opposite. It could be that kids with ADHD, because they are, have a lot of challenging behaviors, that parents may choose to have them watch more TV than other kids, or because they're engaged by that, because they pay attention to that, they slow down a little bit, or seemingly slow down a little bit as a function of that. It also could be a third factor. Could be that that a third factor that's related to both the screen viewing and the ADHD that's causing that correlation. So it could be that I'm trying to think of what the third factor might be in this case, but the point I'm trying to make is that the response would be that there really aren't any experiments showing that there's a causal relationship here. And in fact, it would be very difficult to do a causal experimental study on this factor, and that there are much stronger research studies, some of which have some experimental bent to them, that have shown that ADHD is caused by physiological and genetic factors, and that is the primary driver for ADHD symptoms, and that these other factors like screen viewing and so forth may exacerbate symptoms, may be associated with them, but they're by no means causal.
Well, thank you, Dr. Depaul, so much for your time with us today. At the National Resource Center on ADHD, we often hear from parents who are wondering if their young children are showing symptoms of ADHD and what their next steps should be. I think you've addressed many of those concerns today, and I think this has been very helpful for our audience members.
Well, you're welcome, and thank you all for being interested in this topic and for participating today. Thank you.
Thank you. For our audience members, we hope you've enjoyed this presentation. Please take a moment to send us your feedback through the survey that will appear on your screen at the end of this webcast. On Tuesday, April 14th, we are welcoming Dr. Jerome Schultz again to discuss what professionals need to know, say, and do, helping children understand their ADHD. This is a special webcast with guidelines for professionals. You can register now at help4adhd.org or on the CHADD website at chad.org/asktheexpert. Thank you again for participating with us today, and we hope you enjoy the rest of your day, and hope that you will join us again in our future webcasts.